Okay, so my name's John Grainger. I'm a paediatric haematologist up at Manchester Children's, and I'm delighted to be invited to come and talk today around paediatric ITP. The focus of my talk is going to be around some of the data that we've gleaned from the Paediatric Registry, but also talking about some of the other general advances in paediatric ITP. So paediatric ITP, a little bit of terminology first of all. We tend to refer to newly diagnosed ITP as in sort of the first 3 months. And newly diagnosed ITP will occur in about 5 in 100,000 children in the UK. And virtually all children who present with ITP will have no primary underlying medical illness, which is what we call primary ITP. For children compared to adults, most children will recover spontaneously within a few weeks and have very few bleeding problems. Persistent ITP is what we define as having gone on for more than 3 months, and chronic ITP for more than 12 months. And these will occur in approximately 1 in 100,000 children. Obviously, the longer the ITP's gone on, the longer it is likely to continue to go on, and the chance of going into spontaneous remission drops, but never reaches an absolute that the child will not recover. Most children with persistent and chronic ITP still have a safe platelet level and are free from bleeding and can carry on with most normal activities. However, those with severe thrombocytopenia, i.e. a platelet count below 20 to 30, continue to remain at risk of bleeding and continue to need to take some lifestyle modifications, and many will need ongoing therapy to support them and prevent dangerous bleeding. ITP treatments you will have heard about before, certainly for the adults. We tend to break treatments into what we call first line and second line. For me, first line is what we're using to rescue a child from actual bleeding. These may be in the form of steroids or immunoglobulins, which only transiently lift the platelet count up, and then the platelet count will subsequently drop back down again as these treatments clear. For children, the treatment we use most commonly is what we call watch and monitor, i.e. we're not giving any direct therapy to boost the platelets and are waiting for the disease to naturally get better. Second line therapy is what we are talking about when we're referring to really disease modifying treatment. These are treatments that are going to lift the platelet count for a substantial period of time and will raise the platelet to a safe level and prevent bleeding. They are not necessarily cures, but they are allowing the child to be safe and having a normal lifestyle. And these treatments are usually things like the TPO mimetics, i.e. L-Trompag or Romilostim, immunosuppressants such as rituximab, mycophenolate, cyclosporine, etc., or surgical procedure splenectomy that is now very, very rarely used. The final part of treatment that we must never forget is the most important element, which is supportive care. That includes education, reassurance to families, support from organisations like ITP Support, and also necessary lifestyle changes. This supportive care also includes certain medical treatments such as tranexamic acid, iron replacement, and hormonal therapies. So going back onto paediatric ITP, and what we're going to be talking about here is obviously we're going to be looking at what treatment patterns we're using in the UK and how these have changed recently, and what are also some things that we've learned from elsewhere, such as the upfront immunoglobulin study and some of the clinical trials that have been conducted in children. We're also going to just have a little look at what the new guidelines say and how they've changed from previous. I know they've been covered a little bit by Adrian earlier, and also a bit on what we also need to learn moving forwards. So the ITP Registry is fully funded and supported by the ITP Support Association, and we initially sort of launched this locally in around 2007, moving to a national initial trial in 2008. Over time, we've added things such as more quality of life measure. We've had better support from various research networks to support the study. And then we've also, as we've had more treatment for chronic ITP in children, focused a little bit more on the chronic ITP, looking at side effects there, patient self-reporting of bleeding, And recently, which is still ongoing and hopefully going to be launched within the next 6 weeks, is a latest ITP update, which makes the registry look a little bit smoother and also work smoother. And there'll be sort of more links in there for families as well. This slide here demonstrates how we have seen sort of people sort of being sort of taken into sort of the registry. In the UK, we think there's probably around sort of 400 children per year with ITP. And we can see back really over the last 4 years, and the 2019 is back up again around the 300 mark. So based on sort of about 400 children in the UK per year, we've been recruiting over half of the children in the UK since 2014, and are now recruiting about 3/4 of the children. That's different to all other registries around the world because we're capturing the vast majority of children, whether they're referred to specialist centres, whether their ITP gets better quickly and doesn't need any therapy. So we think it gives us a much better impression of what's really going on. This slide here looks at what sort of the natural course of paediatric ITP in our registry as time goes on. So this bottom x-axis is time since the initial presentation. And this faint blue line here is when the child has actually entered into remission. And you can see sort of remissions occurring even within the first 4 weeks. So sometimes it's going away as quickly as it started. By 3 months, over half the kids, the ITP has gone into remission. And by the time we're at sort of the year mark, that's down to about 75%. This dark blue and the dark red arm here is really where you got a platelet count of less than 20 and less than 10. And you can see quite a marked drop off, but then really from the 6-month mark onwards, it stays fairly steady out there at around just under the 10% mark. Moving on, we've looked at actually, what's happening to these children and how they're doing. One of the most important things for children is not what the platelet level is, but what bleeding problems they are having. And we tend to sort of stratify bleeding problems between mild, which is mainly just skin changes, the bruises and the pinprick spots, i.e. petechiae. Moderate bleeding, which is sort of where you start to see mucosal bleeding, such as little bits of nosebleeds that may be going on for sort of 10-15 minutes. And then sort of severe bleeding, which is the more significant mucosal bleeding, where you're actually seeing a fall in the hemoglobin where the child is becoming anemic and may even be needing sort of blood transfusion or certainly hospital-based intervention. Life-threatening bleeding is things like bleeding in the head, which is thankfully very rare. And here we can see sort of the instance of these sort of bleeding based on the severity. So the majority of children clearly have mild or moderate bleeding, and thankfully severe and life-threatening bleeding are very uncommon. There's quite a clear trend for children to be older who are having more significant bleeding, and a trend also for the platelet count to be lower, and a trend also for the number of bleeding sites to be higher the more bleeding you're seeing. As you would also expect, most children with mild or moderate bleeding are not receiving any treatment at present, but obviously by the time we're getting into severe bleeding, the vast majority of children are receiving therapy. In an absolute ideal world, we would want to see this even lower for those children just having skin changes, not receiving treatment, and of course we would want to see really 100% of children with severe bleeding getting some form of intervention. But this is just data that's been entered in from local treaters as to what's happening with their patients. What I think of some of the most interesting data that we've had from the registry is looking to how the platelet count responds to individual treatments. So for the children actually who have no treatment, who are presenting to us at the initial time point, they have an average platelet count of 13, which is pretty low as we would expect. We tend to think of a safe platelet count as somewhere over the 20 to 30 mark. So we're coming up to that not long after sort of day 2. At a platelet count of over 50, a child shouldn't even really bruise more easily than anybody else, let alone be at risk of bleeding. So you can see here that over half of the children have hit a safe platelet level within day 7 without any therapy. And that just reinforces why we favour the watch and monitor for the vast majority of children in the UK. Steroids, when we give them, boost the platelet recovery, but not that dramatically. We're hitting, towards a safer level sort of by a couple of days, but not much better than with no treatment. Immunoglobulin in contrast, so those children who had immunoglobulin were more likely to be having significant bleeding, and hence it's not surprising to see the platelet count a little bit lower. And they're hitting a level of over 50 in half of the children within about 24, 48 hours. So it's a really quite good treatment for switching off bleeding. One of the other things that I'm not going to dwell on now, but we'll come back to, is when we look 3 months down the line. There's not really much difference between those who have no treatment and steroids, but those kids who had immunoglobulin seem to be faring a little bit better. And there's obviously a slight question about whether immunoglobulin could be altering the disease. As I said, let's come back to that in a second. We also teamed up with a team in Canada to look at quality of life, to see how treatment affects the quality of life of children. One thing which we did is we compared those children who had no treatment. So the higher the level, the better the quality of life, and the less that the ITP is affecting them from day to day. You'll actually see here, certainly if we compare this arm, which is where parents were reporting how they imagined their younger children were feeling, compared to this arm where the children received steroids, there's a statistical significant drop in the quality of life after steroids, telling us that even if the steroids were improving the platelet count and helping to reduce bleeding, the children felt pretty rubbish and the parents thought their child felt pretty rubbish too. There was no difference really between immunoglobulin and no treatment. We've subsequently done some further work, which I must apologise, I haven't got the slide for due to the lack of time really, which compared an individual child's quality of life and how that changed rather than looking at a pool. And actually, with treatment, for those children who needed immunoglobulin, by nature they tended to be more severe bleeders, they did demonstrate an improvement of quality of life from a time point at time 0 to time point 6 weeks following immunoglobulin, compared to those who had no treatment. Again, as the platelet count tended to improve spontaneously, it improved, but again for steroids it wasn't being seen to improve. So going back to that question about from the data that we saw about immunoglobulin maybe having a better platelet count later on, there was a beautiful Netherlands study which took children with newly diagnosed ITP within 72 hours from diagnosis, under 16 years of age, with a platelet count of less than 20, which is about 80% of all of ITPs, and whom had mild or moderate bleeding. They randomised those kids between watch and monitor and immunoglobulin. What did they see? Well, the aim was to see whether there was any difference in the development of chronic ITP. In immunoglobulin group, 10.2% went on to get chronic ITP and 10.4% in the monitor, i.e. no difference at all. They were, however, more likely to have a better platelet count over the first 1 week, 1 month and 3 months. So there was some good support from the immunoglobulin, but at the 12-month mark, it wasn't making a difference. However, in those who were on the monitor arm, 8 of those needed some subsequent rescue therapy for severe bleeding. And that also included 1 child who had an intracranial bleed, which thankfully made a full recovery and did well. All the children responded to rescue bleeding, but it was just reinforcing that 8 of these 100 children did go on to have subsequently fairly significant bleeding. When we look at it in a bit more detail about whether they were children with mild bleeding or moderate bleeding at presentation, 7 of 8 of those actually had moderate bleeding, so they were in the more severe arm. And what happened to those who had the immunoglobulin? Well, 6 patients in immunoglobulin needed admission, reinforcing the fact that it is not a treatment without any risks or side effects. 2 of the 6 of those were admitted to bleeding because they hadn't responded to the immunoglobulin or hadn't responded quickly enough. and 4 were admitted with headaches or vomiting or fever associated with the immunoglobulin, and all of those settled down within a couple of days. But again, just reinforces that sometimes immunoglobulin can cause a minor issue. But I think the main thing that we took from this and have learned from this is that immunoglobulin given to those children who have more significant bleeding can protect them from a subsequent more significant bleed. And this study, along with some of the other data was taken into account in our guidelines. Again, I know that Professor Newland has talked through to the guidelines, and I'm sure he's emphasized that the guidelines there was a general piece of advice, a guide to how we should be considering treatment. They're not necessarily a rigid rule, and they need to take into account an individual child or adult circumstances. And the 2 main guidelines that we follow is the American guideline and also the international consensus. Many of the talkers, including myself, Professor Newland and Drew Pavon, were all part of the consensus report. The consensus report, although the latter and the ASH guidelines were both published at the same time, the ASH guideline had its last time where it considered evidence as May 2017, whereas the international consensus considered guidance up to January 19, and that causes a couple of minor changes between the 2. In general, the revised guidelines all show a greater emphasis on individualization and quality of life outcomes. For children, there is a recommendation to consider early referral to a pediatric hematologist, especially if the ITP hasn't gone away at the 3 months, or certainly if they're having more significant bleeding. There's again an ongoing emphasis to avoid therapy in the absence of bleeding, but in the consensus, based on that upfront immunoglobulin study, there's a recommendation of increased use of immunoglobulin for those with mucosal bleeding, or close observation if not treating. Moving on to the children with persistent and chronic ITP, the main thing that has changed since the previous guidelines was around the thrombopoietin mimetics, and I've been lucky to be involved very much with both the studies involving L-trompopag and Romilostim. What they've demonstrated for the L-trompopag, for the group who had L-trompopag, which is the dark blue, you can see quite clearly the platelet count coming up compared to those who had placebo. At this point here, patients who were on placebo, who hadn't had any increment on the platelet count, was switched to the open label drug, i.e. everybody was having it, and you can see the ongoing platelet counts improving over time. Again, platelet count isn't everything, so the main discussion point was also about bleeding. And here we can see that at baseline, about 55%, sorry, this is the number, this is, get myself correct, this is the percentage of children, so 55% of children were having bleeding between sort of grade 1 and 4, so any bleeding, and that dropped from 55% to 19%, but more significant bleeding, i.e. bleeding outside of just the skin, dropped from 17% down to 5% as the study progressed. In the Romilostim, we saw very much similar. The black dots represent the platelet count, so the platelet count came up over time on the study. This is the bleeding severity fell down, and this is the more significant bleeding, which again came down. Obviously, there's still the occasional little blip up and down here. On the back of those studies, the drugs were subsequently licensed for children, both in North America and the UK. But obviously what families are always wanting to know, and doctors were also wanting just to be able to reassure families that these drugs are safe. So in the L-trompopag, we saw very little difference in dropout rates of people on the drug between the L-trompopag, so 2.8% came off the drug compared to 2% on the placebo. We did see a few liver abnormalities when we were monitoring them for children on L-trompopag. So 4% of Caucasian children had a rise in their liver tests, and 18% for children from an East Asian background. So quite clearly we do need to keep an eye on the liver tests. changes in the eye. So in 2 patients on the L-Trompopag study who had also received quite big doses of steroids, there was some changes in the lens of the eye. Nobody went on to develop cataract, and as I said, they'd all received high doses of steroids, which can also cause changes in the lens of the eye. Similarly, in Romilostim, we had discontinuation of the drug in about 1.4%, and we saw antibodies against the Romilostim, which is stopping the Romilostim working in about 3% of the children on the study. Long-term data for both L-Trompopag and Romilostim is now over 10 years in adults, and a few children have also been on this treatment for over 10 years. We see remissions, i.e. they're able to come off the medicines and still run a safe platelet count in between 20 and 50% of children, and these remissions can occur as early as 6 months and continue to be seen longer term. We have not seen any new safety data of anything that was worrying us, and there is plans for sort of more studies to be looked at more aggressive weaning in both children and adults who have been on longer term use of these drugs. So going back to the consensus report, what are the recommendations there? Again, for newly diagnosed, it recommends for children with mild or moderate that most can be monitored with watch and monitor, but treatment and hospitalization, certainly for those with more significant bleeding, and recommend either a short course of steroids or immunoglobulin when a more rapid response is needed, which will certainly be the case for more significant mucosal bleeding. When we get into the persistent and chronic phase, again, most children will be running a safe platelet count of over 20 to 30 and can be just monitored with steroids or immunoglobulin given as rescue if there is an intermittent drop in the platelet count or a procedure such as dental extraction is needed. But otherwise, for those children who still have a significantly low platelet count, use of drugs and tend to favour the TPO-RAs, i.e. Romilostim and L-Trompopag, and then considering switching between the drugs or rituximab, and very rarely splenectomy. So that when we go to the registry data and have a look at what's actually been done for these children in the UK, when we look at second line therapies, and we deem that people are eligible for second line therapy if they've had ITP for over 6 months and still have a platelet count of less than 30. And what we're seeing currently is about 23% of such children are receiving a second line therapy. And currently, the therapies that they're receiving, half of them are receiving the TPOs, a quarter rituximab, and then the rest is made up, of other immunosuppressants, and a very small number still going on to splenectomy, usually when the other treatments have failed. The current average length of time to get in such treatment is about 12 months. Again, this data represents before these guidelines were put out, and it'll be very interesting again to look over the next 5 years to see how that changes. So in conclusion, most children with newly diagnosed ITP can be managed with supportive care. The majority will have mild bleeding. Most do not require any additional special investigations, and we should only admit and treat severe bleeding or moderate bleeding. And in the moderates, those who have multiple bleeding sites may be at particularly higher risk of more significant bleeding later on. Children should be referred to pediatric hematologists if the ITP is still going on at 3 months, or there's any unusual features in the ITP at the beginning. Children with persistent and chronic ITP, the first treatment that we would generally recommend are the TPOs, which we've now got fantastic data on, and we know are safe, and they work for the majority of children. Splenectomy generally nowadays is only used for those who have failed all other medical therapy. And these drugs which we're using here are quite specialist, and there is a certain skill to using them, and that means really these should only be prescribed by pediatric hematologists who are used to looking after children with ITP. The areas of future research which we're starting to explore within the registry is obviously, firstly, we want to look for hints of any possible underlying abnormalities, especially in the immune system, that might predispose to ITP and might affect our treatment decisions. We want to look at the data from the Netherlands group and see how that correlates with the children from the UK. And we've got a team who is currently already starting to look at that. The quality of life measures that we used historically were mainly abound when our only treatments were immunoglobulin, steroids and splenectomy. So the Canadian team have started to explore new quality of life measures that may be more applicable nowadays. Also, since TPOs have been shown to be very good at treating ITP and better tolerated than steroids, we're starting to ask the question about whether it's appropriate to use TPOs earlier than 6 months and possibly even in children with newly diagnosed ITP. Finally, there's also some new therapies that are coming through which look quite exciting, but are unlikely to change things dramatically at this moment in time, but certainly may be useful as an alternative treatment to what we have at the moment, or as useful when those treatment fails. And then finally, want to again just thank everybody for listening to me and inviting me to the talk today. And I'm sure there'll be an opportunity for taking questions later. Thank you.